I'm Dr. Jean Jose, Department of Radiology, University of Miami, Medical Director of the Lennar Foundation Medical Center. We're here to introduce you to the fundamentals of musculoskeletal ultrasound imaging. I'm joined by Louis Payro, Ultrasound Supervisor for the Lennar Foundation Medical Center, and Nikhil Patel, medical student of the University of Miami School of Medicine, that will serve as our patient. Thank you.
Hey, this is Richard Wang, one of the radiology residents. I'll be going over basic MSK ultrasound evaluation of the ankle today. First, I'll go over some ultrasound basics, and then I'll go over the anatomy and technique for parts of the ankle, and then the pathology, and finally end on a video demonstration. Tendons and ligaments both have an echogenic fiber-like pattern. Ligaments are more compact. Muscles are hypoechoic with echogenic lines denoting the paramecium surrounding the muscle bundles. Nerves have a fasciculated appearance with hypoechoic individual nerves and surrounding hyperechoic epineurium. For evaluation of the ankle, we'll be using the two left high-frequency linear transducers. Make sure to look out for anisotropy to avoid confusing tears with artifact. For evaluation of the Achilles tendon, place the patient prone with the foot hanging off the edge of the examination table. Visually compare both sides to see if there's any difference in position of the feet. Start by placing the probe at the myotendinous junction and follow the tendon down to the calcaneal insertion in both long and short axis. Tears are most common about 2 to 6 centimeters above the calcaneal insertion at the watershed zone. For the lateral ankle, place the transducer behind the lateral malleolus to look at the peroneal tendons. The arrowheads denote the peroneus brevis tendon, and the white arrow denotes the peroneus longus tendon. Check them at the level of the peroneal tubercle of the calcaneus denoted by the void arrow. Check the peroneus longus down to the os peroneum, and then check the peroneus brevis to the attachment at the base of the fifth metatarsal. For the anterior ankle, have the patient seated on the examination bed with the knee flexed 45 degrees so that the plantar surface of the foot lies flat on the table. There are 3 extensor tendons to examine: the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. Follow each of the extensor tendons down in long and short axis. Look at the adjacent tibialis anterior artery, and then you can also look for fluid at the anterior recess of the tibiotalar joint. For the anterolateral ankle, slightly invert the forefoot to stretch the lateral ligaments. To examine the anterior tibiofibular ligament, place the probe parallel to the floor with the back edge at the lateral malleolus. Then, rotate the probe's front edge to find the anterior tibiofibular ligament. For the calcaneal fibular ligament, dorsiflex the foot and have one end of the probe at the lateral malleolus and the other end pointing down towards the heel. For the medial ankle, place the patient in frog leg position. Place the probe behind the medial malleolus like in the top set of images in order to see the posterior tibial tendon and the flexor digitorum longus tendon. If you move the probe more posteriorly, you can see the flexor hallucis longus tendon. Follow the tendons down to the respective insertions, and then you can also evaluate the neurovascular structures within the tarsal tunnel, like at the top and middle set of images. The curved arrow denotes the tibial nerve. Next, we'll take a look at the deltoid ligament as seen on the bottom set of images. The tibiotalar portion of the deltoid ligament can be examined while dorsiflexing, with one end of the probe on the medial malleolus and the other end pointing towards the back heel. As you pivot the probe anteriorly with one end of the probe kept on the medial malleolus, you can see the tibiocalcaneal and tibionavicular portions. For the plantar foot, you want to place the patient prone and then place the probe at the plantar aspect of the hindfoot. Measure the plantar fascia where it leaves the calcaneal tuberosity. Here we have a case of extensor digitorum longus tenosynovitis. The top image is a long axis view and the bottom are short axis. The top and bottom left show fluid around the tendon with arrows pointing at the synovial hypertrophy of the tendon sheath. Color Doppler on the bottom right shows increased vascularity. Here we have a tear of the peroneus brevis tendon. The left shows a short axis view and the right a long axis view, where you can see the peroneus brevis tendon divided into two separate bundles. So the Achilles tendon does not have a tendon sheath, so it technically cannot have tendinitis. When you see fluid, you can refer to it as peritendinitis or peritendinitis. The left image is a short and long axis views of a normal Achilles tendon. The right are short and long axis views of an Achilles tendon with hypoechoic and thickened peritoneum around the Achilles tendon. These images show the Achilles tendon. So on the top left you can see the arrow pointing to a thickened Achilles tendon. Bottom left you can see with Doppler there's increased flow, and on the right you can see some retrocalcaneal bursitis deep to the Achilles tendon. Here we have two separate examples of full thickness tears of the Achilles tendon. The affected site is usually 2 to 6 centimeters proximal to the calcaneal insertion at the watershed zone. Sometimes you can see a hyperechoic hematoma in this region as well. At the top set of images, the arrows are pointing to the retracted tendon stumps. On the bottom set of images, the arrows point to the anechoic tear itself. These images show a normal and sprained anterior talofibular ligaments. On the right, the anterior talofibular ligament is denoted by the arrows, and it's thickened with a deep surface tearing shown at the arrowheads, which represent a partial tear.
Basic ultrasound evaluation of the ankle by placing the patient prone with their feet sticking out of the bed in a degree of dorsiflexion. We will use a linear 18 transducer, and we'll begin by interrogating the back of the ankle and the distal calf, starting at the short axis, looking at the medial and lateral heads of the gastrocnemius and the soleus as they unite to become the Achilles tendon. We will follow the Achilles tendon in short axis all the way to its Achilles insertion. And we will do the same in long axis, working our way down, looking for tendinosis or tears. When we reach the level of the calcaneus posteriorly, we will look for any fluid collection, namely retrocalcaneal bursitis. The next step is to evaluate the lateral aspect of the ankle. The main tendons we're going to be interrogating are the peroneal tendons, the peroneus longus and brevis tendons. We will use a short footprint linear transducer. The peroneal tendons will travel posterior to the level of the lateral malleolus. We will start in short axis, working our way down. We will document integrity of the tendons, any fluid around the tendons, and also their positioning, making sure that they're not subluxed out of the lateral malleolus and extending distally towards the base of the fifth metatarsal. We will evaluate the anterior and posterior inferior tibiofibular ligaments, the anterior and posterior talofibular ligaments, and the calcaneofibular ligament. We will look to the anterior lateral gutter of the tibiotalar joint to detect the presence of a tibiotalar joint effusion. The third part is evaluation of the anterior aspect of the ankle. We will begin by placing the transducer in a short axis to the anterior extensor tendons, and we will follow each tendon, including the tibialis anterior, extensor hallucis longus, and extensor digitorum longus, both in short axis and also in long axis. We will also evaluate the dorsatus pedis artery and peroneal nerves, and the anterior recess of the tibiotalar joint, looking for a tibiotalar effusion. A medial ankle, we will begin by evaluating the long medial flexor tendons. These travel posterior to the level of the medial malleolus, and they include the posterior tibial tendon, the flexor hallucis longus, and the flexor digitorum longus tendons, and we will follow them both in short axis and also in long axis. The most important tendon to interrogate here is the posterior tibial tendon, which will travel closest to the medial malleolus and will insert into the medial aspect of the navicular bone. Lastly, we will check the deltoid ligament by placing the transducer between the medial malleolus and the calcaneus, interrogating both anteriorly and posteriorly for any gross disruptions. Lastly, we can check the anteromedial gutter of the tibio-tibial joint to look for any cysts or joint effusion. The posterior tibial neurovascular bundle, including the tibial nerve, the posterior tibial artery, and veins, can be seen at the level of the tarsal tunnel. And we can evaluate for any masses. Lastly, we evaluate the plantar aspect of the heel, looking for any tears or inflammation of the plantar fascia. We use a long footprint linear transducer, an 18. We will place it along the plantar aspect of the foot, starting at the calcaneus and working in a long axis view towards the tip of the toes, interrogating the plantar fascia for tears, inflammation, or masses. Then we will also evaluate it in short axis all the way to its distal insertion.